Good morning, everyone. So today we are starting a series of lecture which will cover infectious diseases. It will include bacterial, mycobacterial, fungal, protozoal, and helminthial infection and viral diseases. The first class is on bacterial and chlamydial infection. So as we all know that the infectious disease is an important health problem worldwide, and it is one of the leading cause of death, particularly in the elderly people with and the people with AIDS, chronic diseases, and on immunosuppressive drugs. The most important reason is unsanitary living conditions and the malnutrition, which contributes to the massive burden of infectious disease, which is more than 10 million deaths per year. The infectious diseases mostly affect children and causes respiratory and diarrheal infection, which are the most common cause of death. So there are various infectious agents which are already known. They are prions, viruses, bacteria, fungi, protozoa, and helminths. Today we will be discussing on bacteria. The bacteria are usually 0.2 to 15 micron in size. They could be obligate intracellular, extracellular, or mostly they are obligate intracellular and extracellular. They can be classified as pyogenic bacilli, gram-negative. There are multiple ways of classification of them. We'll see one by one in the next slide. So bacteria are basically prokaryotes and they have cell membrane but lack cell membrane bound cell organelles. So the nucleic acid is directly in contact with the cytoplasm, and they don't have cell membrane bound nuclei and the organelle, in opposed to eukaryotic nuclei which have a cell membrane bound nuclei and the organelle in the form of mitochondria, ribosomes, endoplasmic reticulum. These type of organelles are lacking in the bacteria. They usually have a capsule, nucleoid, cell membrane, ribosomes, and flagellum if they are motile. Bacteria have peptidoglycan cell wall, which is polymer of long sugar chain linked with the peptide bridges. They could be thin-walled or thick-walled. If they have thin-walled, thick wall surrounding the cell membrane, they retain the crystal violet stain, so that's why they are called as gram-positive. And if they are thin-walled with cell wall sandwich between the two phospholipid bilayer membrane, then they are gram-negative. These details will also be covered in the microbiology, so I will not be covering most of the microbiological aspect. I will just focus on the pathology aspect. So there are multiple classification of bacteria. They can be classified as gram positive and negative based upon gram staining. They can be classified as depending upon their shape as cocci or bacilli. If they are spherical, they are cocci, otherwise they are bacilli. Depending upon their need of oxygen, they are classified into anaerobic and aerobic. With presence of flagella, they are able to move. If they are pili, they are able to attach to the host cells or the extracellular matrix. So these are multiple shape of the bacilli which we can be seen. They can be cocci, they can be rod shape which are called as bacilli. They can have irregular or spiral shape. These are also a type of bacilli. So normally bacteria are present in they can colonize on the skin, they can be present in the mouth and also GIT. They are basically normal commensal also in our body. Most of there are approximately 395 species of the normal intestinal flora which are known, and many of them remain extracellular and will invade the body. They survive and replicate either outside or inside the host, and they are called as facultative intracellular or obligate extracellular. Bacteria are potential agent for bioterrorism. Most commonly is anthrax and Clostridium botulism. Because they readily disseminate or transmit from person to person, there is a high mortality and high potential for major public health impact. There can be public panic and social disruption, and they require special action for public health preparedness, and they lack a specific therapy. They are stable and they require very small dose for causing the infection. The most common is anthrax, which is already known. So what is the mechanism of tissue damage and infection? Usually the tissue damage is caused by contact or entry into the host cells, which cause the cell death. They release toxins which kills the cell at a distance by enzymes which degrades the tissue and damage the blood vessels and cause ischemic necrosis. They induce host immune response and which cause further tissue damage. So coming to the common gram-positive bacterial infection, the most common are Staphylococci, Streptococci, and Enterococci, and each causes many types of infections. So, a single species can cause multiple types of infections. These are usually gram-positive rods, which includes diphtheria, listeriosis, anthrax, Clostridia, and Nocardia. And the diagnosis is based upon culture and the special tests like PCR. So, staphylococcal infection most commonly caused by Staph aureus. They are pyogenic gram-positive cocci. They are forms cluster like bunches of grapes. The common infection caused by the Staph aureus includes boils, carbuncle, impetigo, Staphylococcus scarlet syndrome, abscesses, sepsis, osteomyelitis, pneumonia, endocarditis, food poisoning like condition, and toxic shock syndrome. So you can see that practically from the skin to almost each part of the body or each organ is infected, or most common organs are infected by the staph infection. Staphylococcus epidermidis are the opportunistic infection, and they are commonly caused in the catheterized patient and patient with prosthetic wall and patient who are drug addict. Staphylococcus saprophyticus are the common cause of UTI in the young women, particularly who are sexually active. Staph, coming to the most common, Staph aureus. Staph aureus has a surface protein for adherence and evasion of the human host immune response. The secreted enzymes degrade the host protein, and toxins damage the host cells. This secreted protein can also cause antibiotic resistance. They express receptor for fibrinogen and fibronectin and vironectin to bind the host endothelial cell. They have a polysaccharide capsule which allows Staph epidermidis to attach to prosthetic wall in case of Staph epidermidis and the catheter, and they resist phagocytosis. The lipases present degrades the lipid on the skin and helps to produce skin abscesses. Protein A binds to the Fc portion of the immunoglobulin, and these organisms escape the antibody-mediated killing. Staph aureus produce Staphylococcus produce different type of toxins. The alpha toxins are the pore-forming toxin which intercalates into the plasma membrane of the host cells and depolarize it. Beta toxins are sphingomyelinase. Gamma toxins are leucocidins, lyses, which lyse RBCs and phagocytic cells, and delta toxins cause detergent-like peptides. So exfoliative A and B toxin cleaves the desmoglein, and because of which the keratinocytes detach from each other, and there is loss of functional barrier, and which cause secondary skin infection. Exfoliation occurs locally at the site of infection, cause bullous impetigo, or it can cause disseminated loss of superficial epidermis, which is called as staphylococcus. So if it is a localized, then the condition is impetigo, which is a small boil-like condition, this thing. And if it is a disseminated, then it causes Staphylococcus scarlet syndrome. Staph aureus superantigen cause food poisoning and toxic shock syndrome, and toxic shock syndrome cause renal failure, coagulopathy, liver disease, respiratory disease, generalized rash, soft tissue necrosis at the site of infection. If not promptly treated, it can be fatal, and this condition can also be rarely caused by Staphylococcus pyogenes. Super antigens binds to the MHC and TCL receptor beta chain, release large amount of tumor necrotic factor and IL-1 and cause septic shock-like feature. So now coming to the morphology, when there is localized infection which is commonly caused as impetigo, you can see that there is a boil-like boil which is seen on the gross examination. On the morphology, there will be presence of acute neutrophilic inflammatory infiltrate in the superficial, which is sloughing of the overlying epidermis and present in the superficial dermis focally. If there is formation of carbuncle, you will see a lot of inflammation which is present mostly in the dermis. It will be more in the larger areas. You can also see foreign body type of giant cell reaction. When there is furuncle, you will see a lot of inflammation and foreign body type of giant cell reaction around the hair follicle and the hair shaft. In case a specific condition which is called as hidradenitis suppurativa, you can see that the sweat glands are mostly involved by the inflammatory process. It causes infection of the nail bed, which is called as pyronychia, and phalons, which is infection of the palmar side of the fingertip, which is extremely painful and which follows trauma, or usually follows trauma. It may also destroy the bone of the terminal phalanx if it is not treated immediately. Staphylococcus is one of the common cause of lung infection, and whenever it infects the lung, it will form multiple abscesses. Usually lobar pneumonia is the typical presentation caused by staph lung infection, and on histology you will see that there is polymorphonuclear infiltrate, that is neutrophil rich acute inflammatory infiltrate, and there is severe tissue destruction. This tissue destruction is such extensive that it will form multiple abscesses. You can see that on gross examination you will see that there are multiple small cavitatory lesions which are filled with pus or acute inflammatory exudate or abscess, and the wall will have some amount of fibrosis because the body will try to restrict the inflammatory response. And on histology you will see all neutrophil rich inflammatory infiltrate and multiple microabscess formation because of extensive tissue damage. Staphylococcal scalded syndrome frequently occur in children, and it is infection of nasopharynx or because of infection in nasopharynx or the skin. There is a sunburn-like rash over the entire body which evolves into fragile bullae, and there will be partial or total loss of skin. The disformation of the epidermis at the level of granular cell layer will be there. Toxic epidermal necrolysis or Lille's disease is secondary to drug hypersensitivity and which cause disformation at the dermo-epidermal junction. So as we have seen that the staphylococcus can infect the multiple organ and cause multiple disease. In the respiratory infection, it causes pneumonia. It can cause toxic shock syndrome. It can cause food poisoning like condition. It can cause endocarditis, particularly in the prosthetic wall. It can cause skin infection in the form of carbuncle, impetigo, furuncle or abscesses. It can also infect the bone, and which is one of the common cause of osteomyelitis. Now coming to the next common bacteria causing infection is streptococcal and enterococcal infection. These cause supuratory infection of the skin, oropharynx, lungs and heart. This is one of the cause of rheumatic fever and immune complex GN and erythema nodosum. Streptococcal and enterococcal infection caused by multiple group of streptococci, which include streptococcal pyogen, streptococcal agalacti, streptococcal pneumoniae, viridans group, and streptococcal mutans. Streptococcal pyogens cause most commonly pharyngitis, scarlet fever, erysipelas, impetigo, and rheumatic fever. Streptococcal agalacti colonize in the female genital tract and cause sepsis and meningitis in neonates and chorioamnitis in the pregnancy. Streptococcus pneumoniae, which is alpha hemolytic, are most common cause of community acquired pneumonia and meningitis in the children. The viridans group of streptococci are most commonly responsible for endocarditis, and mutant group of streptococci are responsible for causing dental caries. The diagnosis of streptococci are obviously made by culture and rapid antigen test for pharyngitis. Enterococci are often resistant to common antibiotic, and they have relatively low virulent bacteria and usually cause endocarditis and UTI. Streptococcal pharyngitis, pyogenes, agalacti, and pneumonia are they have capsule and resist phagocytosis. Streptococcal pyogenes have M protein that prevents from being phagocytized, and C5a peptidase degrades the chemoapoptotic protein, so the membrane complex cannot attack it. Post-streptococcal acute rheumatic fever is probably caused by anti-streptococcal M protein antibodies. The T cell crosses, these are the cross react and with the cardiac protein and cause the rheumatic fever. Streptococcal pyogenes are the rapidly progressive cause rapidly progressive necrotizing fasciitis, or which is also called as flesh-eating bacteria. There is pneumolysine, which is released on disruption of streptococcal pneumonia, which inserts into the host cell membrane and lyses, and they greatly causes the tissue damage. They activate classical complement pathway and reduce complement for opsonization. Streptococcal mutants produce dentin caries because it metabolizes sucrose to lactic acid, which demineralize tooth enamel and secrete glucan that promotes aggregation of bacteria and the plaque formation. Erysipelas, which is the most common seen in middle-aged man, which is seen in the warm climate. The exotoxins from the superficial infection with the streptococcal, it is caused by the exotoxins from the superficial infection of the streptococcal pyogen, and this is rapidly spreading the erythematous cutaneous swelling, which is seen on the face and less frequently on the body and the extremity. So on clinical examination, you will see that there is a sharp, well demarcated serpiginous rash with a serpiginous border. Sometimes it will have butterfly pattern of distribution. On biopsy, you will see that there is edematous neutrophilic infiltrate in the dermis and superficially into epidermis, which can extend into subcutaneous tissue. There can be formation of microabscesses, and tissue necrosis is usually minor. So inflammation will be more and necrosis will be a little bit less. Streptococcal pharyngitis, the most common antecedent of the post-streptococcal glomerulonephritis. As you know that the pharyngitis is one of the most common presentation because of the mechanism of molecular mimicry. There will be secondary involvement of kidney, which manifests with the as post-streptococcal glomerulonephritis. In case of pharyngitis, there will be edema, epiglottic swelling, and punctate abscesses of the tonsillar crypts. There will be sometimes there will be presence of cervical lymph node enlargement, and the swelling may sometimes encroach into the airway, specifically if there is pretonsillar or retropharyngeal abscesses. Scarlet fever, it is associated with pharyngitis caused by streptococcal pyogenes, and it is usually seen in the children with age group of 3 to 15 years. There will be punctate erythematous rash over the trunk and inner aspect of the arms and the leg. In face and mouth remains relatively unaffected. Face and mouth are unaffected due to there will be presence of circumolar pallor. The skin will show hyperkeratosis and scaling during the defervences. Just like staphylococcus, streptococcus pneumonia are one of the cause of lobar pneumonia, that is commonly community acquired pneumonia. So just like staphylococci, it will involve the entire lobe, but instead of infection, you will see consolidation in this bacterial infection, and there will be lot of neutrophils which will be entirely filling up the alveolar spaces of the entire lobe. So it's a lobar pneumonia. You will see all stages of lobar pneumonia in the form of initial consolidation, redilatation, gravitation, resolution. The abscess formation which was seen in staphylococci are usually not seen in case of streptococci pneumonia. So extensive necrotic and degenerative abscess formation is usually not seen, like a staphylococcal infection. So coming to the next, diphtheria. Diphtheria is caused by Corynebacterium diphtheriae. These are slender gram-positive rods with clubbed ends. They have more propensity to spread from person to person through the aerosols or the skin exudate. Many of the patients are asymptomatic. Skin lesions are in a neglected wound can be from a neglected wound to the life-threatening infection. Why the diphtheria cause pseudomembrane on the pharynx, and these are toxin mediated damage to the heart, nerves and other organs. Clostridium diphtheriae produce one toxin, that is phage encoded A and B, that blocks host cell protein synthesis, catalyze the covalent transfer of ADP ribose to the elongated factor 2, which inhibits EF2, that is essential for translocation of mRNA into the protein. So basically it blocks the host cell protein synthesis. Diphtheria toxoid does not prevent colonization with the diphtheria, which is usually given as a vaccine, but protects the immunized people from the lethal effect of the toxin. Clostridium diphtheriae proliferates on the nasopharynx, oropharynx, larynx or trachea. There can be satellite lesions in the esophagus and the lower airway. The exotoxins cause necrosis of the epithelium and dense fibrosuppurative exudate. There will be coagulation of the exudate on the ulcerated necrotic surface, creates tough, dirty and gray-black superficial membrane. This membrane will have neutrophilic infiltrate. There will be marked vascular congestion, edema and fibrinous exudate. When the membrane slough off, it has inflamed and vascularized blood. Bleeding and asphyxiation can also occur in the severe cases. Coming to the listeriosis, Listeria monocytogen are the facultative cellular bacilli. They cause usually severe foodborne infection. These are linked to the dairy products, chickens and people who consume hot dog. They can affect pregnant women, neonates, elderly and immunosuppressed patients which are susceptible for the severe infection. Can cause amnitis, abortion, stillbirth and neonatal sepsis. When it infects neonates, it causes disseminated disease, which is and exudative meningitis. Which is also seen in immunosuppressed adults also. Listeria monocytogen escape from the phagolysosome by action of pore-forming listerolysine O and phospholipases. The surface protein binds to the host cytoskeletal protein and induce actin polymerization, which propel bacteria into adjacent unaffected host cells. The resting macrophages which are present in the body cannot kill these bacteria, and it activates macrophages by interferon gamma phagocytosomes. Usually this activation is not happening in case of Listeria infection. Morphologically, there will be acute infection, there will be exudative infection, inflammation, there can be meningitis which shows gram-positive intracellular organisms. In the CSF, the bacilli in the CSF may be sometimes diagnostic. The neonates and the immunosuppressed adults are most commonly affected, and there can be, in the severe cases, there can be formation of abscesses in the lung, liver, spleen and the lymph node. There will be lot of macrophages, but granulomas will not be seen. The infants born with Listeria monocytogen sepsis may have papular red rash over the extremities. There can be abscess formation in the placenta and meconium meso gram-positive organisms on gram staining. So you can see that this is a section from the placenta where there is abscess formation in between the chorionic villi. These are the normal chorionic villi around which there is neutrophil-rich acute inflammatory infiltrate along with some fibrin, which is usually seen in the Listerial infection, which is if it is affecting the pregnant female. Anthrax, which is commonly caused by Bacillus anthracis. These are the large spore-forming gram-positive rods. Spores are ground to fine powder, and it is a potential weapon for bioterrorism. Approximately 20,000 to 1 lakh cases of anthrax are seen each year, and in 1979 there was accidental release of Bacillus anthracis spores in the Military Research Institute in Russia, which killed 66 people. In 2001, 22 people in the US were infected by Bacillus anthracis, mostly through the spores delivered through the mail. So it is one of the common pathogens of the bioterrorism. Normally, it is acquired through the exposure to the animals or the animal products such as wool, which contains Bacillus anthracis. There are three major anthrax syndrome: cutaneous anthrax, which is commonly seen in the 95% of patients, where there is painless purpuric papule that develops into vesicle within 1 to 2 days. Bacteremia in this condition is rare. There is striking edema around the papule. The vesicles rupture and ulcer becomes covered with the black issue. If it dries and falls off as the person recovers. So there will be formation of this type of black color ulcers with the black base, and there will be regional lymphadenopathy, which will also show similar kind of color. Inhalational anthrax, usually it is the cause of death and cause shock within 1 to 3 days. The anthrax the spores are inhaled into the lung. The anthrax spores enter the lung and travel into alveolar spaces, from where the spores are transported to the lymph node, into the lymph node system, into the mediastinal lymph nodes, and where they make toxins and they are deadly. The spores germinate and the toxins are released and cause extensive hemorrhagic meningitis, which is the most common cause of death. Gastrointestinal anthrax is relatively uncommon. It is seen because of eating contaminated undercooked meat. The most common presentation is nausea, abdominal pain, vomiting, followed by severe and bloody diarrhea, and mortality is seen in around 50% of cases, but it is very uncommon. So pathogenesis is just like the similarly seen in the other bacilli. Bacillus anthrax toxins have A and B subunit. B subunit is protective antigen and binds to the cell surface protein. The host proteases clip off the 20 kilodalton fragment of the B subunit and 63 kilodalton fragment self-restitute from the heptamer. The toxins have two alternate A subunit, edema factor and lethal factor. Edema factor or EF binds to the calcium and calmodulin to form an adenyl cyclase, which converts ATP to CAMP, which causes efflux of water from the cell and interstitial edema. Lethal factor is a protease which destroys the mitogen, activates the protein kinase and kinases, and arrests the cell growth and differentiation. So basically, all in the combination of these cause the cell death. So morphologically, there will be necrosis, exudative inflammation. The inhalational anthrax cause numerous hemorrhagic fossa in the mediastinum, enlarged hilar and peribronchial lymph nodes, where the spores are germinating and causing the toxic effects are seen. There will be perihilar interstitial pneumonia and pulmonary vasculitis in the late cases. The mediastinal lymph node shows lymphocytosis, macrophages with phagocytized apoptotic lymphocytes and fibrin-rich edema. Bacillus anthracis can be seen in the alveolar capillaries, venules, and within the alveolar spaces. In the fatal cases, spleen, liver, intestine, kidney, and adrenal glands and meninges are also involved. Coming to the next or last gram-positive bacilli, which is the nocardia. Nocardia are the aerobic gram-positive bacteria which are present in the chains. They are normally found in the soil, and they are the opportunistic infection. Multiple species are seen. Nocardia asteriaceae are responsible for respiratory infection. They can infect skin, can also infect CNS after dissemination from the lung. This infection is usually called when there is defect in the T cell mediated immunity, like the patient who are on steroid, HIV or diabetes. The infection in the most of the cases are indolent. Then the patient present with fever, weight loss, and cough. When the infection is severe, it can affect CNS, and CNS infection can also be indolent, varying from it and have varying neurological deficit. In the skin, it has rapidly progressive infection to slowly progressive lesions. So it depends upon the immunity how the infection manifests. Morphologically, you will see that there is a suppurative inflammation with central liquefaction surrounding the granulation tissue, surrounding granulation tissue and fibrosis. Granulomas are not seen. So you will see the colonies of bacilli around which there is centrally there is liquefaction and there is surrounding granulation tissue and fibrosis. The bacilli can be identified by performing gram stain and modified AFB stain. These are gram positive bacilli in the branching filament pattern, and modified AFB stain shows that these are acid fast bacilli, AFB positive bacilli. So these are gram positive as well as modified AFB positive. So after gram positive bacterial infection, let's move to the gram negative bacterial infection. The most common gram negative infection are caused by Neisseria. These are gram negative diplococci flattened on the adjoining side. These are having coffee bean appearance. They are aerobic, having stringent nutritional requirement. They grow best on the enriched media, which such as lice, sheep blood agar. They are clinically significant because they cause Neisseria meningitis and Neisseria gonorrhoeae. Neisseria meningitis is one of the common cause of meningitis in the children below the age of 2 years. The bacteria usually colonize the oropharynx and spread by the respiratory route. Approximately 10% of the population in the is colonized at any one time, and these episodes last for several months. Immune response usually leads to the elimination of the organism, and this response is protective against the subsequent disease. That means sufficient amount of antibodies and T cell mediated response is produced so that in subsequent infection the damage is not very extensive. Bacteria invades the respiratory epithelial cells and travels into the basolateral aspect side of the and enter the blood vessel. The capsule inhibits the opsonization and destruction of the bacilli by the normal complement pathway. Serial infection are seen where there is innate defect in the membrane of attack complex, because complement is only way to kill these bacteria. Neisseria gonorrhoeae, which is now uncommonly seen, is an important cause of sexually transmitted diseases. In men, it presents with urethritis. In women, it is often asymptomatic. If untreated, it can lead to pelvic inflammatory disease, infertility, and ectopic pregnancy. Diagnosis is by culture and performing PCR for this organism. The infection is usually local in the genital or the cervical mucosa or the pharynx or an rectum. In the disseminated infection is seen where there is deficient membrane complex or the complement pathway defect. There can be septic arthritis, rash of hemorrhagic papules and pustules. The neonatal infection can sometimes cause blindness and rarely sepsis. Eye infection, there is installation of silver nitrate, we can identify by installation of silver nitrate, or antibiotics can be treated. Coming to the pathogenesis, it uses antigenic variation to escape the immune response. Multiple serotypes are seen. Meningitis on exposure to the new strain. Organisms adhere to and invade the non-ciliated epithelium at the site of entry, usually nasopharynx, urethra, and cervix. And to the next infection, which is whooping cough, which is very uncommonly seen nowadays, caused by Bordetella pertussis, which is also one of the type of gram-negative cocci. It causes an acute and highly communicable illness, and paroxysm of violent cough followed by a loud inspiratory woof. That's why the name is whooping cough. There is an active vaccination which is available, So because of which this is quite rare nowadays. The diagnosis is done by PCR as the culture is less sensitive. The Bordetella pertussis colonizes the bacterial bronchial epithelium and invades the macrophage. The virulence factor regulated by the Bordetella virulence gene, that is BVG. BVGS is a transmembrane protein that phosphorylates BVGA, which regulates transcription of mRNA to the adenosine and the toxins. So, Bordetella pertussis cause adherence to the ciliated respiratory epithelium and cause surface mucodepletion. And there is multiplication which followed by entry, and there is persistence and transmission. When there is systemic intoxication because of pertussis toxin, adenyl cyclase toxin, there is tracheal cytotoxins and dermonecrotic toxins which cause local mucosal damage and paroxysmal cough. So all these toxins are responsible for local mucosal damage and paroxysmal cough. It can cause tracheobronchitis. The bronchial mucosal erosion, hyperemia and copious mucopurulent exudate can be seen. The lung alveoli remain intact. There will be peripheral lymphocytosis, which is seen approximately in the 90% of the cases. There will be hypercellular and there will be hypercellularity and enlargement of mucosal lymph follicles and peribronchial lymph node enlargement. Coming to Pseudomonas. Pseudomonas is one of the commonest opportunistic infection caused by aerobic gram-negative bacilli. This is a deadly pathogen of people with having cystic fibrosis, severe burn and neutropenia. Many people with cystic fibrosis die due to pulmonary failure secondary to the chronic infection with Pseudomonas aeruginosa. Pseudomonas aeruginosa can be resistant to antibiotic, and it often infects extensive burned skin or skin burn, which is the most common cause of hospital acquired infection and hospital acquired pneumonia. Pseudomonas infection can present like a keratitis in the contact lens wearers, endocarditis or osteomyelitis in the IV drug abusers, cause external otitis externa in the healthy individual, and severe external otitis externa in the diabetic. There is a pili and adherens protein that binds to the epithelial cell and the lung mucin, which express endotoxins, and there are signs and symptoms because of release of sepsins. Endotoxin A inhibits protein synthesis by ADP ribosylating and ribosomal protein EF2. Exoenzyme S, which is ADP ribosylated RAS, and other G protein that regulate cell growth and metabolism. Phospholipase C lyses RBCs and degrades the pulmonary surfactant. Elastases degrades the immunoglobulins and extracellular matrix. It produces iron-containing compound that is extremely toxic to the endothelial cell and may cause vascular lesions. So it can affect the patient who are wearing contact lenses, patient with trauma, patient with epithelial diseases or epithelial defect, where the organism can be opportunistic infection and cause invasion and destruction. Pseudomonas cause necrotizing pneumonia through the and grossly you will see that there is, just like staphylococci, there will be extensive necrosis and abscess formation, but instead of neutrophil rich inflammatory infiltrate, you will see lot of necrotizing lesion, that is a complete necrosis of the lung parenchyma, which is surrounded by the hemorrhagic rim, and microscopically you will see lot of necrosis and inflammation. There will be masses of organisms cloud the tissue with bluish haze concentrating in the wall of the blood vessel. The host cells undergo coagulated necrosis. So you will see lot of coagulated necrosis, and in the central part you will see that there is destruction of the blood vessels because of presence of bacteria, and you will see presence of bacteria around it. So there will be extensive necrotizing pneumonia, the most common cause is because of endothelial cell damage or the blood vessel damage caused by the bacilli. These bacilli are gram-negative and can be identified by performing gram stain. There can be bronchial obstruction by the mucus plug, and the pseudogenous erythemangitis infection are the frequent complication in the cystic fibrosis. In the patient with bronchiectasis and pulmonary fibrosis, this is one of the most common infection which cause respiratory failure. It can also cause, it can be seen in the skin burn where it proliferates, penetrate deeply into the vein and spread hematogenously. You will see well demarcated necrotic and hemorrhagic oval lesion on the skin, which is called as erythema gangrenosum, and because of its spread hematogenously, it can cause disseminated intravascular coagulation, which is a frequent complication, common cause of death. Now coming to the plague, which is called as Yersinia pestis, which is caused by Yersinia pestis. It is the gram-negative facultative intracellular bacterium. It is transmitted from rodent to the human by flea bites. It is less common from it is the human-to-human transmission by the aerosol is little bit uncommon, and it causes invasive and fatal infection. Plague is also called as Black Death, and it is usually in the form of epidemic, and it is the various type of Yersinia bacteria are known, which includes Yersinia enterocolitica, pseudotuberculosis, and Yersinia pestis. Yersinia pestis is the most common organism which cause the plague. When the Yersinia proliferates, it forms hemorrhagic suppurative lymphadenopathy, which is called as bubo, and this type of plague is called as bubonic plague. So Yersinia pestis, which goes into the lymph node, it causes the enlargement of lymph node, and at this stage it is called as bubonic plague. But once there is hematogenous dissemination and it goes into the lung and it causes respiratory complication and pneumonia-like condition, then it is called as pneumonic plague. The organism have a complex of genes which enables the bacteria to kill the host phagocytes. Yersinia pestis cause lymph node enlargement, which is called as buboes. It can cause pneumonia, which leads to sepsis and striking neutrophilia, which is called as pneumonic plague. Histologically, there will be massive proliferation of the organisms. The protein-rich and polysaccharide-rich effusion with minimal or few inflammatory cells, but with marked tissue swelling. There will be extensive edema, but inflammatory response will be less. There will be necrosis of the tissue and blood vessels with hemorrhage and thrombosis, and there will be neutrophilic infiltrate which accumulates adjacent to the necrotic area as the healing begins. So once the healing starts, there will be inflammatory cell recruitment in the periphery, and it will start accumulate around the necrotic area. So in the bubonic plague, you will see that there is lot of lymph node enlargement and it can rupture. In the pneumonic plague, there will be secondary involvement of the lung in the form of pneumonia. So bubonic plague, when there is involvement of the lymph node. Pneumonic plague, when there is severe confluent hemorrhagic and necrotizing bronchopneumonia with often fibrinous pleuritis. So you will see that there is extensive hemorrhagic and necrotizing bronchopneumonia. So instead of inflammatory infiltrate, there will be lot of necrotizing inflammation. If it is not treated, then there will be a septicemic stage where there will be the lymph nodes throughout the body, and the organ rich in mononuclear infiltrate develop fossa of necrosis. There will be fulminant bacteremia, and it can cause DIC with widespread hemorrhagic and thrombi, which cause the death. Coming to chancroids, which is also called as soft chancres, they are acute sexually transmitted and ulcerative infection caused by Haemophilus duceri. It is in tropical and subtropical areas. It is seen and usually it is seen in the lower socioeconomic group. Chancroids are one of the most common cause of genital ulcer in the African and Southeastern Asian country, but in India it is relatively uncommon. Chancroids are usually formed 4 to 7 days after the inoculation in the form of tender erythematous papule which develop over the external genitalia. In the male, it develops on the penis, and the females on the vagina or the periurethral area. After several days, the surface erodes and produces the irregular painful ulcer. The ulcer is not indurated. There can be multiple lesions, and base is covered with the shaggy yellow gray exudate. There will be regional lymphadenopathy because of infection, which enlarges in around 50% of the cases in 1 to 2 weeks. If untreated, the inflammation enlarges. There will be lymphadenopathy, and which may erode into the skin to produce a chronic draining sinus. So sinus formation will be there. In the microscopy, you will see superficial zone of neutrophilic rich debris with fibrin. There will be zone of granulation tissue containing area of necrosis, and dense lymphoplasmatic infiltrate will be present beneath the layer of the granulation tissue. The cocobacilli can be sometimes demonstrated by gram or silver stain, but because the inflammation is so much that usually the bacilli are obscured by the inflammatory infiltrate. Granuloma inguinale are caused by, which is also called as donovenosis. It is chronic inflammatory disease which is sexually transmitted. It is endemic in certain tropical and subtropical region. It causes extensive scarring, lymphedema, and elephantiasis of the external genitalia. The diagnosis is done by microscopy and microscopy of the smears, or sometimes by the biopsy. Donovenosis have usually present with the raised papular lesion on the moist squamous epithelium of the genitalia, rarely in the oral mucosa and oropharynx. As the lesion enlarges, the borders become raised and indurated. There is disfiguring scar development in the untreated cases, and sometimes associated with the urethral, vulvar, and anal stricture. There will be regional lymphadenopathy, and the lymph node will show only non-specific changes in contrast to the chancroids. So grossly you will see ulcer formation with abundant inflammatory granulation tissue formation, which manifest as and the edges will be raised. These are usually soft and painless masses. On histology, there will be pseudoepitheliomatous hyperplasia of the overlying skin, particularly in the adjacent non-ulcerated area. There will be neutrophils and mononuclear infiltrate. Giemsa stain can show minute encapsulated cocobacilli in the macrophages, and Warthin-Starry stain or other silver stain can be sometimes helpful in demonstrating the organisms. Coming to the next, relapsing fever, which is caused by insect transmitted disease, which is usually louse-borne. It is a recurrent fever with spirochetemia, and it is epidemic. It is also called as epidemic relapsing fever. There are multiple epidemics in the African, East Europe, and Russian in the first half of the 20th century, infecting 15 million population. Endemic relapsing fever is transmitted from the small animals to the human by tick-borne infection. The incubation period is approximately 1 to 2 weeks. There will be shaking, chills, fever, headache, and fatigue, followed by DIC and multi-organ failure. Spirochetes are temporarily cleared out from the blood by antiborrelia antibodies. It can be cleared. After a few days, the bacteria with new antigen emerges and reaches the high densities in the blood, and the symptom returns. Successive attacks and spontaneous cure in many untreated patients are seen. So because of multiple relapses, it is called as relapsing fever. Lyme's disease caused by several species of Borrelia burgdorferi. It is a common arthropod-borne infection in the US, Europe, and Japan. It is transmitted from rodent to the pupil by Aedes deer ticks. The diagnosis is by serology and PCR. It is a tick bite which produces erythematous papule, erythema chronicum, migrans, and lymphadenitis. In the CNS, it produces present like the meningoencephalitis and cranial neuritis. When it affects the heart, it produces heart block, pericarditis, myocarditis. In the bone, there will be destructive chronic arthritis. So there are 3 stages. In the first stage, there will be acute illness, which after weeks, there will be stage of dissemination, and from week to month, there will be chronic stage or late stage formation. The pathogen is secondary to the immune response against the bacteria, and initial response is stimulated by binding of the bacterial lipoprotein to the TLR2 expressed by the macrophages. There will be release of pro-inflammatory IL-6 and TNF. In the skin, it forms skin lesions, and it can cause arthritis where there is lot of synovial proliferation with subsynovial lymphomononuclear infiltrate along with histiocytes. Coming to the brief about the anaerobic bacteria, there are oropathogenic anaerobes, which includes Clostridium difficile colitis with antibiotic treatment, or environmental anaerobes like tetanus, botulism, gas gangrene. Abscesses can be caused by anaerobes, like these are various species which can cause abscess. We'll briefly discuss some of the forms. The Clostridial infection, which is called as Clostridium perfringens, tetani, botulinum, and difficile. Clostridium perfringens and septicemum cause cellulitis, myonecrosis, which is called as gas gangrene, uterine myonecrosis, sometimes mild food poisoning, infection of the small bowel associated with ischemia, neutropenia, and severe sepsis. Clostridium tetani cause tetanus, which is potent neurotoxin, which cause contraction of the skeletal muscle and lockjaw. It is the most severe form caused by Clostridium tetani. Clostridium botulism grows in the canned food and cause release of potential neurotoxins that blocks the synaptic release of acetylcholine and cause severe paralysis of the respiratory and the skeletal muscle, which is called as botulism. Difficile causes pseudomembranous colitis, particularly the patient who are treated with antibiotic. So when there is cellulitis, there is extensive myonecrosis and myocytolysis, and because it is a gas forming organism, there will be subepithelial formation of air spaces. That's why the condition is called as gas gangrene. You can demonstrate these organisms by performing stain or by performing cultures. Coming to the chlamydial infection, chlamydia proliferate only within the cell, although some may survive outside the cell. They enters the cell through the initially there will be formation of endosome. The ribosome fissions and inclusions. There will be formation of inclusion which grows. After 12 years, there will be inclusion with the cell membrane, and then there will be there will be exocytosis, and there will be release, and how they will spread. These are basically small gram-negative bacteria. Chlamydia trachomatis are the common cause of urogenital infection and inclusion conjunctivitis. It cause STD, enters the vagina through the semen, that is the sexual transmission. Bacteria will pass through the cervix and enters the uterus, and then enters the fallopian tube, ovary, which can become infected. An infection can leave fallopian tube and spread into other part of the body through the peritoneal cavity. C. trachomatis can also cause lymphogranuloma venereum, which is the non-gonococcal urethritis, which is a natural infection most commonly seen in the sexually transmitted bacterial disease in the world. You will see that there will be neutrophil-rich acute inflammatory exudate surrounded by palisading histiocytes. That's why the name is lymphogranuloma venereum. It can also cause epidermitis, prostatitis, pelvic inflammatory disease, pharyngitis, conjunctivitis, perihepatic inflammation, and proctitis. The diagnosis is by culture in the human cells, but amplified nucleic acid test is performed on genital swab or urine specimen are more sensitive than the culture. It can also cause ocular infection, which is in the children, which is called as trachoma, and which can cause blindness, but it is quite uncommon in in India nowadays. Chlamydia urethritis is a mucopurulent discharge containing the predominance of neutrophils. The organisms are not visible on the gram stain smear or on the section. LGV, there will be mixed granulomatous and neutrophilic inflammatory response. There will be the inclusion are seen in the cytoplasm of the epithelial cell or the inflammatory cell, and there will be formation of stellate abscess with surrounding histiocytes, which gives granuloma-like appearance. Coming to the rickettsial infection can be in the form of epidemic typhus, scrub typhus, or spotted fever caused by multiple species of rickettsia. This part mostly it will be covered in the microbiological part, in the microbiology section. So I am not going to cover it in detail. It can cause typhus fever, scrub typhus, rocky mounted spotted fever, hemorrhagic rash which extend into the entire body, are usually hemorrhages. Thank you.